start with our first session. Can you give me the first PPT, please? This is the session on monoclonal antibodies, and I would like you to open page number 5. Everybody has the booklet, everybody has the ball pen. This is an informal fill-in-the-blanks quiz. First, I'll just introduce monoclonal antibodies to you. जिस तरह GLP-1 receptor analogs या twin cretins, GIP plus GLP-1 receptor agonists are revolutionizing the therapy of diabetes, and much more is going to come. Similarly, monoclonal antibodies are revolutionizing therapy of various complex diseases not treatable by the current regimens or medicines. So, for example, denosumab is a monoclonal antibody. We have discussed that on the group yesterday. So, what are monoclonal antibodies? Monoclonal word means the antibody what is produced in the lab. All the antibodies will bind to only one antigen. So, all are clones of each other. How are they produced? They are produced using either animal B lymphocytes or human B lymphocytes or a mix. So, they can be chimeric or chimeric, so to speak, hybrid, or they can be isolated from mouse only or from humans only. So, various types of monoclonal antibodies exist. And what are they used for? They are used for suppressing an antigen or creating antibodies from our own cells towards that antigen. So, they have multiple mechanisms of action. Right? So, for example, if you remember in COVID, we used to give casirivimab and imdevimab. What would they do? They would have they would attack the spike protein on the surface of the SARS-CoV-2 virus. So, they will either attack that or stimulate our immune system to attack that, is what generally the monoclonal antibodies will do. What is the difference between the antibodies that we already have and monoclonal antibodies? Monoclonal antibodies are a large number of antibodies. So, we are giving a dose which is much higher than our body can produce. What is the advantage of being monoclonal? The advantage is that they will have only one antigen to attack. Chemotherapy in cancer will have multiple side effects because they will attack the normal cells also. Monoclonal antibodies principally will attack only the target. So, they are targeted therapy. What is the disadvantage? They have allergic reaction. That is the principal disadvantage for us. Because they are produced from other sources like mice, other humans, etc., they can have allergic reactions. The other problem is that they are expensive to create. So far, they are very expensive to create. But monoclonal antibodies is a distinct future of pharmacotherapy in many areas. Hence, our knowledge, even though all are injectable, we should know more about them because gradually their use will increase. So, even in therapy, in diabetes therapy, जब मैं पढ़ता था तब मेटफॉर्मिन था और वो पुराने सल्फोनिलुरियाज थे और कुछ नहीं था, राइट? आप लोगों में से कई लोगों ने वही एक्सपीरियंस किया है. But now it has gradually increased. We have so many diabetes pharmacotherapies which we have learned recently, much after our college education level was over. So this is another area where we will have to keep on learning much more. So this is just an introduction. You are not going to use these molecules mostly, but you should know about them. Okay, so the fill in the blanks, you have to fill in the blanks as we go along. Next slide, please. These 3 slides we have discussed yesterday. So I'll just revise them. The last 3 letters, MAB, monoclonal antibodies. The letter preceding MAB tells us the source from where it is manufactured. U indicates human source in denosumab. The part preceding the source letter indicates the disease or target, usually indicates that. So denosumab mein OS refers to osteoporosis. Next slide, please. These are the various sources. So O will be used for mouse, XI will be used for part human, part mouse. ZU will be used for mostly human, part non-human, and only U will be used for human. This is the part preceding the MAB. Next slide, please. So now let us play. Denosumab is typically recommended for DASH when bisphosphonates are either contraindicated or not tolerated. Osteoporosis. Very briefly, one line on each. Denosumab is overused by orthopedic surgeons, by maybe physicians, and we should give first preference to bisphosphonates. Only in patients with CKD, low GFR, we may not be able to use bisphosphonate, and then denosumab comes into an action. But the efficacy for both is the same. They are, neither is superior to the other. Next slide, please. Adalimumab, rituximab, and infliximab may be used to treat DASH when drugs like methotrexate, sulfasalazine acetate fail. So the clue is given already. So it is rheumatoid arthritis. If you see rituximab, the MAB stands for, what is XI stand for? Part human, part non-human, and Ritu, I don't remember, I don't know what it stands for. Kumar, do you know what Ritu will stand for? But basically, immunotherapy, IT could be immunotherapy, for example, because this is a form of immunotherapy. Okay, next slide, please. Idarusizumab, difficult name. Idaru, the first part of the name, Idaru, is chosen by the pharmaceutical company or by the researcher. It is not signifying anything specific. They just try to make it fanciful. Idarusizumab can reverse serious bleeding that occurs as a complication due to dabigatran, DABIGATREN. You know that in India we have three principal NOACs available, newer oral anticoagulants. Dabigatran, rivaroxaban, and apixaban. All these three are often to be monitored or used by us. So this is something that is, I'll be touching one area of indication maybe later. So one of them, if they cause bleeding, like if warfarin causes bleeding, what do we do? What is the antidote? Protamine. Protamine is an injection. If dabigatran causes bleeding, this monoclonal antibody, which is very expensive, can be used to stop. Next, please. This is something that you will be more familiar with. Trastuzumab. Trastuzumab is a targeted adjuvant therapy for HER2 positive breast cancer. So HER2, what is HER2? HER2 is a protein on the breast cancer cell. And if HER2 is positive, that breast cancer cell can be destroyed, killed by the antibody to HER2. So this antibody is a trastuzumab. Next, please. Anti-CD20 monoclonal antibodies, like rituximab, are widely used to deplete B cells in the treatment of B cell cancers like non-Hodgkin's lymphoma and various kinds of leukemia, but CLL, for example, is one. Rituximab. What is CD20? CD20 is a receptor. There are multiple CDs and receptor on B cells. And this B20 is a typical receptor which is on the cancer cells of non-Hodgkin's lymphoma or leukemia. And this, therefore, can be targeted by rituximab. Rituximab, as you know, is also used in rheumatoid arthritis. Again, there, the same CD20 protein is expressed on the abnormal cells. Next, please. MABs like ranibizumab and bevacizumab. Some of you may have taken these injections for yourself or for your relatives. They primarily target the VEGF, vascular endothelial growth factor, and are used as intraocular injections for ARMD or age-related macular degeneration. AMD it is also called. There are two types of age-related macular degenerations. One is proliferative and one is non-proliferative. So if there's proliferation, it means proliferation of microvasculature or blood vessels. And this blood vessel proliferation can cause retinopathy and blindness. If there is AMD and if it is proliferative AMD, you can reduce the growth factor with these two drugs. Multiple injections are often necessary, as you already probably know. Next, please. Rabies shield is an MAB used as a component of DASH. Post-exposure prophylaxis of rabies infection. Which patients require post-exposure prophylaxis? Most important to say is those patients require post-exposure who have not taken pre-exposure prophylaxis. That is the most important thing. All of you, I strongly recommend, all of you should take the rabies vaccine pre-exposure, before the bite. 2 doses only required, 0 and 7. You must take the dose so that if a dog bite does occur, then you can get away with only 2 more doses of the vaccine, 0 and 3, without taking the immunoglobulin like rabies shield. Right? India is considered the world capital of rabies. 20,000 deaths per annum in India. The world's greatest number of stray dogs are in India. Correct? And one very interesting thing is the stray dogs are increasing because of diclofenac. Why do you think? Sorry? Yeah, vultures are being killed by diclofenac in the cattle. Cattle are given diclofenac. That cattle after death is eaten by vultures. Vultures take in diclofenac, their kidney goes, vultures die, vulture population is decreasing. That vulture population decline is supposed to cause, according to one statistic, 50,000 deaths per annum in India because of vultures not being able to eat rats. Leptospirosis, not being able to eat dogs. Rabies. So that, what is, you see that butterfly effect. Yeah, next please. Erenumab is a monoclonal antibody that blocks CGRP receptor, which plays a key role in migraine pathophysiology. Erenumab is available in India. It is a drug used for prophylaxis of migraine, not treatment of migraine. It is an injectable drug and it's an expensive drug. But if you have a migraine patient who is not responding to standard preventive therapy like propranolol, etc., then you may consider giving this injectable. It has to be given every 2 to 4 weeks, multiple doses. Next, please. Evolocumab, Repatha, is an MAB used to lower LDL-C levels when maximum dose of oral drugs do not achieve the target. Repatha is a brand name. Erenumab. Again, there are some people with familial hypercholesterolemia and very aggressive atherosclerosis and death at a young age within the family. In these patients, some people some cardiologists have preferred to use this drug because this can lower the LDL levels to up to 0. LDL can go below 10 very easily with this injectable. In patients who need aggressive, because they have had, so you will have patients who have had 1 angioplasty, then 2nd angioplasty, then 3 stents more, and then bypass, and then again angioplasty. These patients with aggressive atherosclerosis, their LDL has to be kept very, very low as possible. And evolocumab helps there. Evolocumab, human source or non-human source? Human, because of the U. And C probably, LOC probably says lower cholesterol. Maybe, we don't know. Okay, next please. Subcutaneous omalizumab is an anti-IgE agent useful in severe, not adequately controlled with standard therapy. So there are two MABs that are being used in allergic conditions or atopies in India. There are more abroad. One of them is omalizumab. So if you have a patient who has severe asthma, uncontrolled with nebulizers, and patient requires steroids recurrently, oral steroids recurrently, you may consider for omalizumab injectable. The requirement for omalizumab is because it is an anti-IgE agent, the serum total IgE levels have to be high. Only then will omalizumab be very effective. So the second agent is, next please. While omalizumab works in patients with high IgE, mepolizumab, the spelling is wrong, Mopali likha hai, MEPOLIZ, Mepol, Kumar right, say na, Mepoli na? MEPO, mepolizumab works in patients with asthma with significant what? Eosinophilia. So if you have a patient who doesn't have high IgE, but has very significant eosinophil count, maybe more than 1,500, then mepolizumab will work as an anti-asthma injectable. Next, please. Tocilizumab. We have all heard of tocilizumab in COVID times, right? Tocilizumab is an effective alternative to steroids in DASH, a condition that can cause severe temporal headache with sudden blindness. Temporal arteritis, also known as GCA, giant cell arteritis. As you know, giant cell arteritis is a condition which presents with temporal headache, often unilateral to begin with, can become bilateral. Patients have tender temporal artery, and patients have significantly high ESR, high CRP. Patients on sonography will show typical features of inflammation of temporal artery. Temporal artery biopsy is the correct test, but nobody does it. The problem with temporal arteritis is that if you don't diagnose it and treat it in time, it can cause blindness. So you have to give steroids as soon as you suspect temporal arteritis, even clinical suspicion with high ESR, high CRP. In some and many patients, you will have to give long-term immunosuppressive therapy, which can be methotrexate, which can be steroid. But some patients will not respond, their headaches will continue, and these patients, you may have to give tocilizumab. So as you see, most MABs currently are being not as first-line therapy. They are used as resistant case therapy. Next, please. Rituximab, again, is an alternative to splenectomy for patients with DASH. ITP. Rituximab is an alternative to splenectomy for a patient with ITP when the disease is refractory to steroids. Again, ITP, as you know, it can be acute ITP, chronic ITP. Recurrent ITP or chronic ITP is often treated by removing the spleen so that the spleen does not destroy the platelets, but not often will it be successful. Then you have to use this immunosuppressive therapy. So that is your monoclonal antibodies. Any questions, please ask. I am not an authority on monoclonal antibodies. I am learning with you. But if there is any question, maybe Kumar can solve it or I can solve it.